Now pause for 5 seconds.
The world's biggest democracies. It occupies around 60% of the Amazon forest and has the world's longest beach. I think Dr. Nito will be hosting us a conference very soon on the beach because they can occupy the most of the Indian members on that beach. It spans around 24,000 feet long. And it also is the largest country in the world when you take a longitudinal wise from north to south, spanning 2,800 miles. And of all that, the Brazilian heart is also very big. They are so accommodative people, smiling people. We are really happy to be associated with the Brazilian chapter launch. So with this, thank you, Sahu sir and Dr. Saurabh Patwardhan, who has been instrumental in getting us connected with the Brazil and with Dr. Neto, who really picked it up. And I'm sure that all of us will witness one of the wonderful webinars. It's been launched in the international platform. So with this kind introduction about the Brazil, I like our founder chairman, Dr. Amulya Sahu sir, who has been very pivotal role and instrumental in setting up a chapter in Brazil, to please say a few words.
Well, it is my proud privilege to introduce this chapter, and Neto had been a wonderful connection, and I have opened chapter in many places, but the energy and dynamism with Neto is really infectious. So I'm looking forward to a lot of things, and ISMSIC is a growing family, and we have opened chapters in all the states of India. I expect the same thing in Brazil. They should go to the grassroots level, because they see we have been wonderful. We have tremendous surgeons before the PECO, and after the PECO also there will be surgeons who will perform artistic work with their hand. So SICS we have taken to a next level. So now I feel Brazil will compete with us and give the best to this field. Thank you so much, and welcome all of you to this chapter.
Thank you, sir. Thank you for welcoming. The words come from the founder chairman of ISMSICS Society. And now we go in for the chairman of ISMSICS Society, who is another stalwart in SICS and has been very instrumental in the growing and the growth of ISMSICS, not only nationally, but also internationally. I now call upon Dr. Jagannath Boramani, sir, to please say a few words. Sir, you are muted.
Yeah, can you hear me now?
Yes, sir.
Yeah, good evening, all of you. I'll just go rapidly through the journey of ISMSICS, because this talk has been repeatedly told in so many installation ceremonies, but mainly for our Brazilian counterpart. I'll rapidly rush through the slides. ISMSICS was formed in 2005. Our founder chairman was Dr. Amulya Sahu, and as on today, we have live members about 2,000. After the launching, immediately we started with multiple national events. The first one was in China, international event, China, followed by Malaysia, 2007, 3 days big conference, followed by 3 days conference in Indonesia. This conference was under the aegis of ISMSICS. Then in 2009, there were 3 international events in Egypt, Sweden, as well as in Philippines. Philippines also was a 3 days big conference. We had a big conference in South Africa in 2013, along with the workshop and live surgeries. In 2015, in APACRS, we conducted a wet lab. ISMSICS conducted a wet lab. Then we used to publish, I was the editor of the journal. We used to publish the physical copies of the journal. Almost 7 issues were published. And we are again starting with the new editor, the launching of the new journal. Then from 2015 onwards, we started having world conferences every 2 years. So in 2015, the first conference was held in Pune. The second was in 2017, jointly with Arvind Eye Care Systems. And in this conference, we also entered with Help Me See, which is a big NGO, international NGO. They're into simulators, the simulator in SICS surgeries. In 2018, World Conference, World Ophthalmic Congress, ISMSICS conducted a wet lab in Barekar Eye Institute. And in this conference, our book, Master's Guide of SICS, also was launched. We had multiple CMEs across India, and then we had partners or like sessions in various conferences in India. And our third World Conference was 1 year back in Kolkata, jointly with Disha Eye Hospitals. We have been given big stage in All India Ophthalmic Congress successfully for 2-3 years, 2 big halls. We participated also in WOC 2020, which is a virtual one. And our next conference, annual conference, will be in Chandigarh, India, which will be in 2021. This was a conference in US, which was announced in 2013, but this will be shifted to 2015. And in 2013, we'll be having our biennial conference with LV Prasad Eye Institute, India. We have presence in almost all states of India and almost 20 countries outside India.
It is not
affiliated.
13,
Yes.
It is not 2013.
Okay.
2013 is by mistake.
Okay.
25.
Yes. 25. Correct. Yeah. And we have been affiliated to All India Ophthalmical Society, and there are a lot of plans like affiliation to International Council of Ophthalmology and starting ISMSS recognized training centers across the world. We will be having surgical training program in Tanzania and other African countries. And these are the glimpses of launching ceremony in Egypt and Bangladesh. In the COVID pandemic, we had multiple international and many state webinars. And recently we conducted Ophthalmic Women of Substance Bangladesh chapter webinar, US chapter installation and webinar. And this is our website, www.ismsics.com. Those who wish to join can join by joining through the link given below. Thank you very much.
Thank you, Boromani sir, for explaining the journey of ISMSICS Society, how in a hard way it has come out so well and it's growing nationally and internationally. And do we have Dr. Parikshit Gogate here and Dr. Satanshu Mathur, Chief National Coordinator of ISMSICS Society? If they have not yet joined, and I think they'll be coming in a while, and they'll be.
You can see Admin Parikshit. Admin Parikshit name is there. I don't know.
Okay. So with this, myself, Secretary of ISMSICS Society, Dr. Srinivas Joshi, takes pleasure in inviting and installing all the office bearers under the National Office Bearer team, including Dr. Sahu, Dr. Boromani, Dr. Bhattacharya, who's the President of ISMSICS Society, Dr. Parikshit, the Vice Chairman of ISMSICS Society, Dr. Satanshu Mathur, Chief National Coordinator, and Dr. Deepak Mishra, who is the Joint Secretary of ISMSICS Society. So I'll just start our installation ceremony, and I'm sure that you are able to see my screen. So first we have the chairman of the ISMSICS Society of Brazil chapter, Dr. Nito Rosatelli, who obtained his medical degree from the Faculty of Medicine, Ribeirão Preto, the University of Sao Paulo, ophthalmic residency training at the Clinical Hospital of Ribeirão Preto, master's degree in medicine from the Faculty of Medicine, University of Sao Paulo, and is presently the ophthalmologist private practice from 1990 to 2018. He is a fantastic dynamic cataract surgeon under the contract from the Brazilian public health system since 1999. And I'm sure that you all will be amazed with his fantastic surgical skills. And the last time he spinned us all around with his phaco spin. And here comes I request Dr. Amulya Sahu sir, our founder chairman, to please install him with the virtual medal. And here comes the medal, and just offer him the virtual bouquet. Next, I'll be installing a Vice Chairman, Dr. Rafael Kobayashi, Surgical Optics Division, Department of Ophthalmology, Paulista School of Medicine, Federal University of Sao Paulo. I request Dr. Jagannath Boromani sir to please offer him the virtual medal and offer him a virtual bouquet. Welcome, Dr. Rafael. And here comes installing our president, Dr. Walter Noose, Associate Professor, Surgical Optics Division, Department of Ophthalmology from Sao Paulo, is also the director of the Paulista School of Medicine, Federal University of Sao Paulo. So I request Dr. Debashish Bhattacharya sir to please install him with the virtual medal and the bouquet. Thank you, Dr. Walton. Welcome to the family of ISMSICS Society. And it's my privilege to install our Vice President of the Brazil chapter, Dr. Felipe Taguchi, who is the Surgical Optic Division, Department of Ophthalmology, Paulista School of Medicine, Federal University of Sao Paulo. So I request our Vice Chairman, ISMSICS Society, Dr. Parikshit Gogate, to please install him with the virtual medal and the bouquet. Welcome, Dr. Philip. And it takes proud pleasure to introduce the secretary. I think in most of the societies, the secretary has a very dynamic role to play, and I'm sure that Richard Hida will make India and Brazil proud by conducting more and more programs. He is also the Department of Ophthalmology from Paulista School of Medicine, Federal University of Sao Paulo, and also the Department of Ophthalmology from Kyoto University School of Medicine, Tokyo. So I request our Chief National Coordinator of ISMSICS Society, Dr. Satanshu Mathur, to please install him with the virtual medal and the bouquet. Thank you, Dr. Richard. Looking forward in more and more greater connections with you. And now we welcome our Joint Secretary, Dr. Liang Jung, Head of Surgical Optic Division, Department of Ophthalmology from the Paulista School of Medicine, Federal University of Sao Paulo. I request our Joint Secretary, Dr. Deepak Mishra, to offer him a virtual medal and a bouquet. Thank you, Dr. Liang, and welcome to the society. And now I'll be calling upon the names of the executive members, Dr. Rafael Arantes, who is the Surgical Optic Division from Department of Ophthalmology, Federal University of Sao Paulo. And at this junction, I would like to request our Indian speakers, Dr. Anil Shah sir, to please install him with the medal and the bouquet. And then I would like to introduce our executive member, Dr. Miguel Padilla, the director. I request Dr. Saurabh Patwardhan to please offer him a virtual medal and the bouquet. Thank you, Dr. Miguel, for joining the society. And here comes Dr. Mauro Sicura Campos, the Associate Professor, Surgical Optics, Surgical Optic Division, Department of Ophthalmology, Paulista School of Medicine, Federal University of Sao Paulo. So I request Dr. Ashok Nanda to please offer him a medal and the bouquet. Thank you, Dr. Mauro. Welcome to ISMSICS Society. And it's my privilege to introduce our other executive members, Dr. Lincoln Freitas, Surgical Optics, Surgical Optic Division, Department of Ophthalmology, Federal University of Sao Paulo. I request Dr. Meeta Joshi, Madam, to please offer him a virtual medal and the bouquet. Thank you, Dr. Lincoln, for joining the prestigious society. And it's my proud privilege to introduce our scientific committee members, Dr. Wallace Chaman, Associate Professor, Surgical Optic Division, Department of Ophthalmology from the Federal University of Sao Paulo. I request Dr. Sunil Singh, another panelist, to install him with the virtual medal and the bouquet. And here comes the scientific committee member, Dr. Rachel Gomes, who holds a PhD degree in ophthalmology and visual sciences from the Federal University of Sao Paulo. She completed a postdoctoral as a part of Kenneth Kenyon research team and a member and the editor of Brazilian Society of Cataract and Refractive Surgery. I would now like to request Dr. Sundaram Shetty sir to please offer Dr. Rachel Gomes a virtual medal and the bouquet. Welcome, Dr. Rachel Gomes. And here comes another scientific committee member, a scholar, and is nothing but Dr. Paulo Scor, who is Associate Professor of Surgical Optics, Surgical Optic Division, Department of Ophthalmology from the Paulista School of Medicine, Federal University of Sao Paulo. So I would now like to request our another stalwart of ISMSICS from India, Dr. M.S. Ravindra sir, to please offer him a medal and a virtual bouquet. I now like to introduce our under scientific committee member, Dr. Gustavo Malavasi, who is the director of Clinica Malavasi. I now request Dr. Nivian to please offer him a virtual medal and a bouquet. Thank you, Dr. Gustavo. So with this, we come to the end of the launching ceremony, and I would like Dr. Nito to please say a few words quickly before we go in for the actual presentation.
Well, thank you, Dr. Joshi. I can only say that I'm very honored to be here and installing the Brazilian chapter of the ISMCS. And I think we will have a great time ahead working together for spreading this wonderful technique. And I hope we can we can achieve a very great number of Brazilians in the society interested in learning SICS and other manual cataract techniques. So I personally thank Dr. Amulya Sahu for having invited me, and it's an honor to be here among you.
Thank you so much, Dr. Nito. With this, I think we shall go ahead with the webinar, the CME, and we have a great panel here, Dr. Ashok Nanda, Dr. Meeta Joshi, Dr. Deepak Mishra, Dr. Sunil Singh, Dr. Nivian, Dr. Harsha Bhattacharjee, and Dr. Sunil Thangarajan. I welcome all the panelists to this great meeting. So without wasting much time, let's go on to our first speaker, who is going to spin us around. I'm sure that he is going to talk a different topic today, why a phacosurgeon should definitely learn SICS. Over to Dr. Nito, please.
Okay, can I stop sharing my screen?
Please, please.
Hello, everyone. I'm very glad to be able to talk here, as I would like to take advantage of the opportunity to pass on an important take-home message for both beginner and experienced surgeons. Why you, cataract surgeon, should learn SICS. This will be a very simple and straightforward presentation directed to call attention to the importance of learning manual small incision cataract surgery. But first, what is SICS? The acronym stands for Small Incision Cataract Surgery, but it is something of a misnomer. It is usually used to refer to manual cataract surgery performed via some kind of scleral tunnel, mostly sutureless, and with a wide range of incision size, not only small or under 3 mm in width. So, would manual sutureless cataract surgery be a better name? Well, I'll stick with SICS for now, when I refer to this wide range of types of manual cataract surgeries. Many surgeons are unaware of the fact that after phacoemulsification became the dominant trend in many countries, manual cataract surgery continued its evolution. A wide variety of new manual techniques were devised, and the surgery went through a paradigm shift with advanced scleral tunnel techniques, which provided safety, negligible surgical-induced astigmatism, and no needle suturing. Some techniques are performed with under 3 mm incision width, with topical anesthesia and under very fast surgical time. Many studies have shown that manual small incision cataract surgery has comparable results to phaco concerning visual outcome, inflammatory response, safety, surgical complications, and other aspects. There are many reasons a surgeon may opt for SICS instead of phacoemulsification, ranging from cost issues, eye conditions better approached with SICS, surgery conversion in phaco complications, and even personal preference. SICS is way cheaper than phaco surgery, often tens of times cheaper. No phaco machine needed, minimal and very cheap consumables, possibility of using cheaper rigid IOLs, etc. This affordability makes SICS the ideal choice in prevention of blindness programs. Here are some eye conditions in which SICS provides a degree of safety and feasibility that phaco can't match. Even very experienced surgeons benefit from going SICS in these situations. Similarly, some phaco intraoperative situations or complications are better managed by conversion to SICS. It is mandatory that the cataract surgeon knows how to properly convert to SICS in these cases. A great number of surgeons perform SICS routinely and exclusively in their practice, with outstanding surgical outcomes comparable to phaco. Use of premium IOLs with predictable results is possible, with added benefit of a much more affordable surgery. So, as a take-home message, I would like to stress that SICS is not a lesser surgery. It is an excellent alternative to approach many difficult situations in cataract surgery, and it definitely should be part of every cataract surgeon armamentarium. Thank you very much for your attention.
Thank you, Dr. Nito, for that wonderful presentation on why a phaco surgeon needs to know SICS. Thank you very much. I would like to invite the panelists here. We have an eminent top player from Bhubaneswar, one of the top ophthalmologists of the country, Dr. Ashok Nanda sir, who has a vast experience of more than 30 years in ophthalmic practice. Request Dr. Ashok Nanda sir to please unmute himself. And before that, Dr. Nito, I have a small question. So how are people in Brazil? Because in India, we start with the ECC training and then we switch on to the SICS and then we switch on to the phaco. So how is the training part in the parts of the Brazil?
Well, most of the training programs in Brazil, surgery and residency training programs, are going direct to phaco, and manual cataract surgery is not taught anymore in most of our programs. I think this is a huge mistake, and this presentation was mostly aimed to a Brazilian audience to stress the importance of SICS and that it should be taught, the surgeons should get training as well as they get from phaco. Most younger surgeons in Brazil do not know how to perform manual cataract surgery.
That's why I think the chapter is here for you people, all the stalwarts who have been installed to teach the younger generation. Over to Dr. Ashok Nanda, sir.
Thank you, Dr. Neto. It was an excellent presentation. And Dr. Srinivas, thank you for inviting me to speak something. Actually, in India, we were training people with ECC followed by phaco, but now the trends have changed. SICS is actually a very forgiving technique. So most of the complicated situations you can escape without causing much harm to the eye, whereas ECC or even phaco has severe implications. So that is the reason why the training is definitely much easier if you start with SICS which is a manual technique, and everything is under your control. And as Dr. Neto has said, yes, in almost all difficult scenarios, SICS comes very handy, and it is mandatory for all cataract surgeons to master SICS. Thank you.
Okay, thank you, sir. And I think now we have Dr. Deepak Mishra also here. Dr. Deepak Mishra, is he here? Yeah. So Dr. Deepak Mishra, sir, who is also working as an associate professor in Regional Institute of Ophthalmology in BHU. So he's also training a lot of the postgraduates as well as the undergraduates as well. So what do you think, sir? What's the scenario in India? And what do you comment on Dr. Neto's presentation? Because I'm sure that in Western part of the world and in many countries, still SICS is not that practiced. So what are your views on that?
Dr. Joshi, first of all, the presentation of Dr. Neto was wonderful, and it was beyond expectation. Too many people are doing so much good surgery, particularly the SICS, MICS, which is basically from a gift to word from the Indian scenario. And as far as Indian scenario is concerned, most of the residents, even I can say, even the 70 to 80% of the KM cases are done with this wonderful technique, and even the residents start their basic training in the cataract with MICS, and gradually they shift into the phaco. But the good phaco surgeons should also have good technique, then at which stage they can convert their phaco MICS and how they can proceed. So as far as India is concerned, it covering almost 3/4 of the major surgeries as per my knowledge is concerned. Thank you.
Srinivas, one.
Yes, sir. Go ahead, Sao, sir.
Neto, what do you think if we call it a scleral incision cataract surgery? Because let us not have a dubious name of small incision, because our length of the surgery is not limited to small. So let us call it a scleral incision cataract surgery. So I think we should put this name forward so that we are not in a dubious state. You know, if you do a 9mm incision, you can't call it a small incision. So there, and limit to 2mm. That is one. Number one. Number two is that Brazil, you go with a real resolution to, because here also we had a lot of opposition in the beginning. Now it has become very glamorous. Now everybody wants to do SICS and everybody wants to be with SICS. So same thing will happen in Brazil, because now our SICS surgeon charges the highest fees for the SICS. There is one surgeon who charges 2 million, rupees, 2 lakh rupees for surgery. So people pay it. It is your conviction that makes the difference. So if you say I am the best, then people pay a price for it.
Great.
My thinking, the Brazil will immediately pick up, because they don't, it's not a, so I invest so much. We are giving excellent results. We are doing all the premium IOLs and everything. I think that your confidence will help. I'm very hopeful. Thank you.
Thank you, Sao, sir. I think with 1.3 billion population of our Indian subcontinent, and I think of more than 25,000 ophthalmologists, still 70 to 80% of the Indian ophthalmologists do practice SICS. So I think the details of which probably Dr. Parikshit sir will be explaining in a later presentation. So I now welcome to our next talk, Dr. Lincoln Freitas, who will be speaking on the small incision cataract extraction with manual fragmentation. Over to Dr. Freitas, please.
Hello, it's good morning here in Brazil.
Yeah.
And first I'd like to thank you for letting me be part of these wonderful chapters in India. I feel very close to you because I've stayed in Aravind, Madurai, Tamil Nadu for a while, and I've learned a lot of cataract surgery of there. And also I've been to some meetings in Chennai. So I feel very, very privileged to be here. And I also would like to thank the Brazilian chapter. You know, they are doing a wonderful work to let this happen. And my presentation is called a technique that I've developed. It's called phacosimile. And there are some aspects I would like to comment with you, and I'll just go straight through it. So I had this idea on the 90s to do, instead of a scleral incision, to do a corneal incision with 3 millimeters. I'll do all the phaco steps, but I don't use the phaco machine. Instead of fracturing in 2 or 4 pieces, I fracture in 8 pieces. And then I developed a forceps to grab each of these 8 pieces and remove from the anterior chamber. And also developed a special Cinco, you know, irrigation aspiration. And you can, you know, use injectable or foldable IOL in those cases. When you think about the material development, I developed 3 pieces: the corneal forceps, the chopper, and a modified Cinco. The forceps, this one that you see here, I had some help with from Catena in USA. And that was the, you know, first version that I developed it. And I went through many difficulties trying to work with it. Then I got this version. This version is the 6.0, and it's working very well, and I'll show you. Then I made a modified Dodge-Kaman chopper. I also had some help from Catena in the United States. And the only difference is the angulation on the tip of the chopper to help me work inside the bag without depressing the corneal incision. As you can see here, I can make the fracture. I'm working inside the bag, and I don't lose too much of the viscoelastics or even have a flat cornea from it. And the last part is when you think about irrigation aspiration with the Cinco, and you are working with the, you know, just removing cortex, you don't need more than 0.3 or 0.4. So when you work with phacosimile, you need a larger aspiration area because you're going to remove some of the particles that are remaining on the anterior chamber. So I developed a 0.8 Cinco. And here, just to make a very quick thought, if you have the circumference of the lens around 28 millimeters, and you know, divide by 8, you have each piece of 3.5 on the largest area. And if you either delineate, you can reduce a little bit. So it's smaller than 3.5. And you're gonna see here, it's not difficult to remove the piece. So I do simultaneous incisions, capsulorhexis, hydrodissection, hydrodelineation. Then I go for the phaco, for the lens pre-slice technique. And you can, you know, start aspirating the cortex and make the fracture again. And then you have 4 pieces. And the main problem is, how do you transform each quadrant in 2 pieces, you know, 8 pieces? So what I do, you see here, if you just grab one quadrant and try to remove it from the eye, half of it is going to stay in the incision, as you can see here. Sorry, something went wrong here. Uh-oh. I'll go through it. You can see here, part of that quadrant stays on the chamber. So you have to go back and pick some of these pieces again and remove it. So I'll show you what I do later to transform a quadrant in an eighth of a piece. So then you just have to aspirate and do all over again. This is the last piece. I'm fracturing, removing it. As you have a 3 millimeters incision, you can introduce a foldable IOL without any problem. And the result is really similar to phaco emulsification, since the you don't need a suture and everything ends up very well. And you also, I've tried to work with harder nucleus. This case has a pseudo-exfoliation syndrome. And you can do, you know, small pupil, everything. And despite all of it, if you fracture well and do everything the proper technique, you can remove the pieces and also at the end, put the intraocular lens in the bag, and the results are the same as a phaco surgery. Any pre-fracture, pre-slice, Sakaoshi, even McIntyre, any of them work for it. And how do I fracture from 1/4 the quadrant to 1/8? That's really important. What I do at this time, I don't think you can see my pointer here, but what I do, I hold this 1/4 and I come with the chopper around this forceps and I just, you know, it's grabbing here, no? It's grabbing the piece. The quadrant is here. I come with the chopper and I just do this. So I keep 1/8 in the forceps and remove it. Go back and grab the other 1/8. Could you get it? I don't know, it's clear for you?
Yes, sir.
It's an excellent technique for...
Yes, doctor, it's really very interesting and very impressive.
And this is a very interesting technique for conversion also. This is a patient with uveitis, has a fibrosis, very important fibrosis. I tried to do a capsulorhexis, I end up doing with the venous. And what happened during the phaco, I had a rupture on the posterior capsule, probably because the rhexis was not intact. And you can see here, I was doing the phaco, there is a rupture. Can you see that in the middle? So what you can do is just convert to phaco-similar. And you don't have to, you know, enlarge your incision and just remove the pieces. I had to go and do some vitrectomy, and you end up with an excellent, you know, result. I did a pilot study of this technique.
Time is up, sir.
I'm sorry, I'll go very quickly now. And there is a study done at that time showing that the difference, you know, considering costs, is really something. This is the phaco cost monthly. This is the phaco simile costly monthly. That's the difference. Thank you. Sorry for the time.
Thank you. That was a wonderful presentation, and we all know that there is a huge difference in cost, and we are from countries where cost also is a consideration. So yes, Phaco Smile does give fantastic results, but then we have manual SICS, which gives us similar one. So thank you, Dr. Freitas, for your wonderful talk, and it's so nice to have somebody so honest about what they are doing. May I request Dr. M.S. Ravindran to make a comment on this, sir?
Yeah, this is a wonderful technique. I enjoyed watching his instruments which he has developed way back, maybe 25-30 years ago. And hopefully he's still using them, or they're available on the shelves of trade. I'm not sure who is selling them, but the idea of giving a step to the hook and the nucleus crusher and the tiny incision, they're marvelous. They're just out of the world. Thank you.
Thank you, sir. Dr. Boramani, would you also like to give your comments? Because Dr. Lincoln's this will have so much implications on astigmatism, which is your area of interest.
Yeah. No, this technique was excellent. The way he divides the nucleus into 8 pies was excellent. But I feel this technique might be a little difficult to master. A lot of manipulations in the entry segments are required, and it needs a lot of expertise. The way he divides, you can see that it's very easy in the video, but I don't think it is that easy. You have to practice it a lot to master it. That is my opinion.
Yeah. But one point, why we are not going through sclera, now maybe through limbus, instead of going through cornea, and the same technique can be done. I think it is a wonderful technique, and we all must adapt to it. It's a lot of scope.
But I think everybody is not a surgeon as Dr. Lincoln to be able to give such wonderful results. We also have Dr. Anil Shah from Nandurbar, India, who also uses the Snare. Would you want to make a comment, Dr. Shah? Please unmute yourself, Dr. Shah.
Good evening, sir. The technique is very good, but intracapsular fragmentation is very difficult for common ophthalmologist, and because of that, I think we should need a very practice and all these things. So it is a bit complicated for a junior surgeon. When we remove it into the antechamber, then it becomes very easy for all of us. Intracapsular fragmentation is very difficult.
Thank you, doctor. Thank you for those valuable comments. Thank you, Professor Lincoln, sir. We'll again have more comments at the end. May I request now the next speaker, Dr. Lucas Denadai, who will be speaking on Phaco to ECC conversion.
Parikshit, there's a small change. It's been requested. So we now introduce Dr. Jonathan Lake.
Okay.
To please have his presentation, and then we can go ahead with Dr. Lucas.
Sure, sure. Walking on the moon. Go ahead, sir.
Thank you very much. I'm really happy to be part of the Brazilian chapter here of the society. I think it's very important. I've had experience. I was able to follow Dr. Lincoln with his development of the technique. I have his kit, and I really use it for many situations. It's really worth investing. I really like all the techniques that are here. This will be a little bit different. We will be talking about trabecular micro bypasses and MIGS for the cataract surgeon. Now, there are several types of MIGS, and they have varied techniques and indications, but the bypasses themselves, I think there's a very large overlap with us cataract surgeons, because the glaucoma specialists get harder cases and more advanced cases, whereas we get a lot of initial and moderate cases. And since everybody here has a lot of experience in the anterior chamber, it makes sense to perform a cataract surgery, which doesn't cure but helps in glaucoma surgery, and also implant a stent. And I call it walking on the moon because it's very different. And I love being a cataract surgeon, and I love to be able to see the angle, because we see these different images here. And it's a whole new ambience in which you see these different stripes and different colors, and it really is a whole new landscape and demands a different approach. I think it's very beautiful. I might be wrong, but I think it's the smallest space that any kind of surgeon goes in, so it's worth going back to. And I had to go back to doing gonioscopy, and while performing the surgery, we were able to find some tips for the cataract surgeon, who is not as familiar with this type of ambience as maybe the glaucoma surgeon. And that's why we call this walking on the moon, because you have this whole different sensation. So that's why I do think it's very important. We see the stent right over here. Regarding results, according to glaucoma, I think that is a very important discussion with glaucoma specialists, but you do reach a bypass. And what is more important here? The most important part is looking at the angle. And one of the things that bothered me with gonioscopy reports is that they tend to be coded and complex. So there is a sort of inherent difficulty to this, but really no, it's actually pretty simple if you just base yourself on anchoring on the finding of the scleral spur. Once you find the scleral spur, then you know where you're at. And sometimes it's very easy to find, like in this case. Sometimes it might be harder, like in this case, in which we really have to observe. And I'll show the scleral spur right here. But once you find it, then you know that the trabecular meshwork is anterior and ciliary band is posterior. So basically what we need to know as cataract surgeons is to find the scleral spur, and that will help us find where we're supposed to implant the surgery. Now, this is a trick, and this was kind of accidental, in which we use the trypan blue. And look at this, how you can get a nice coloring. This actually has been published. I'm going to just return to this. And with the trypan blue, you can really see the trabecular meshwork. So I suggest in the beginning that cataract surgeons use trypan blue to stain the trabecular meshwork. This is the first version of the stents. I do suggest for cataract surgeons, and this is among us, that we try to learn this for stent. First, because it's less expensive, it's half price. You can put in 2 or 3, and it also gives you a lot of familiarity with the technique itself. And we all have delicate hands and delicate fingers here, and what we do with the stent is even reach to another level of delicacy during the surgery. So the whole idea here is to not apply any kind of pressure. We locate the trabecular meshwork. This is the most important part. Once you're in, the anatomy of the stent allows you to go in, and then you can apply any kind of force. So what you do is relax your hand, your arm, almost as if the device itself were dropping, and then you implant. Here, I'm going to start applying some kind of strength. You see the eye moves, and then all of a sudden it just kind of glides in. So when you relax your whole upper member, then you're able to implant, and then you'll see it goes in. So this helps a lot in order to learn this type of device. Now there are other versions, there are newer versions, which work with a tacking kind of system. This is very interesting because you have a larger opening. Right now you implant 2, but there will be versions in which you can implant 3 or even more. And it allows you a higher versatility because you can locate and implant, and it is definitely easier. So there are some cases you do have to relax your whole upper member, but it's very visual. You don't really have much feeling. You indent, you have to go in very parallel to the trabecular meshwork, and then you press a button and then it's in. And this bleeding here is very, very important for us to see how it works. What I really like about stents and bypasses in general is the very low morbidity according to the technique itself. So basically the worst thing that can happen is it not being implanted and then basically not working. But there are several procedures that we do during training that allow us to either rescue the first generation, as we can see here. So we rescue it, implant it here into the trabecular meshwork, and then look how I stop applying strength and it goes in. And here with the second generation, we just basically rethread it when it's out and then implant it once again. Now, as I said, the efficacy of this procedure, according to the glaucoma itself, it's not a definite cure, but the main characteristic and the main attraction for me is that it works as a bypass. So here we see with the triclone blue, the trabecular meshwork nice and dyed, so it's a nice blue, but we can see pooling at the collectors. So what I can do is go straight to the collectors, and here we can see an effect. So what it'll do to glaucoma and the patient, it all varies a lot, but we can see that the bypass happens, and this type of outflow is not present before putting these bypasses. So this is a very physical procedure. I think the cataract surgeon should master this type of technique in order to achieve this, and will be able to help diminish, at least bring a very effective treatment at the beginning of glaucoma. So thank you once again for the participation in this Brazilian chapter of the society. I think it's an incredible job everybody's doing here. I'm very happy to be a part of it. Thank you very much.
Thank you, Dr. Lake, for those wonderful videos. I mean, yeah, stents are something that all of us are perhaps slightly wary of, but you have said that, you know, they are the ones that give you such a wonderful this. And yeah, it's not just for glaucoma. So Dr. Srinivas, can we go on to our original speaker, conversion of phaco to ECC? Because in India, mostly surgeons first learn ECC and then SICS and then phaco. Or nowadays, SICS and phaco. But yes, from a personal this, I learned my phaco first and my manual small incision later. So, well, over to you, Dr. Dina Dai. I hope I'm pronouncing it correct.
Yeah, it's correct. So, hello, everyone. I'm really glad to be here. I'd like to thank you, the Brazilian chapter, for the invitation. So my name is Lucas Denadai. I'm third year resident from Brazil. The first video I'm going to present is called Hard Rock Cataract. It's about an 86 years old male patient with hand motion visual acuity. The patient had benign prostatic hyperplasia and was using tensulazine. He presented with atrophic iris and he was not in full dilation. And unfortunately, the iris hooks were not available in the OR at the moment. The patient was under extracorneal anesthesia, and the initial plan was to perform a phacoemulsification with phaco chop technique. As you can see, the capsular rhexis was done just fine, but once I started the phacoemulsification, I've noticed the cataract and the capsular plaque complex had an increased mobility, probably because of zonular weakness, and it was a very hard cataract. So because of these reasons, the cataract hardness, the looseness of the cataract, and the risk of intraoperative flop iris, I have decided to change my initial plan and to convert the surgery to an extra cap to manage the situation. I have chosen to perform another incision and put it aside the clear corner incision. And I did a sclerocorneal tunnel with a large size due to the cataract nuclear diameter. This hard rock cataract have a very big nucleus. The nucleus extraction was done with a vectis and a chopper in a very simple technique. As you can see, the nucleus was very hard. After the cataract extraction, I have decided to insert the capsular tension ring, the CTR, to increase the capsular stability. At that moment, I took the usual steps to remove the cortical material and to insert the IOL inside the bag. You don't need to use the IOL you can use the forceps to insert the IOL since you have a very big incision. This is the final result of the first case. The second video I'm going to present is called Argentinian flag sign. This patient was 55 years old, a female patient with a chief complaint of low visual acuity for the past 5 years. The patient presented with a very hard and mature cataract with a liquefied cortex. The initial capsular tear was done in order to reduce the pressure inside of the capsular bag, but despite the efforts, the central tear became a linear tear that went to the periphery in both ways. So once again, I decided to change my initial plan, and I managed this situation doing an extra cap as well. This patient was also under extracorneal anesthesia, so this decision was easier to do. In most of my cases, I rather do another incision and put it aside the corneal incisions in order to reduce the corneal astigmatism in the post-operative situation. It's very important to maintain a regular scleral flap thickness during the whole scleral flap procedure. I left the nucleus inside of the bag while the incisions were made because the situation was stable. Once again, I was going to use the vectors to remove the nucleus, because it's a very simple technique to do. You have to do a large incision in this case in order to remove the nucleus in an easier way. In this case, I've chosen to insert a 3-piece IOL in the bag with IOL injector, but you don't need to use the injector. You can use the forceps, as you can see in the previous video. So after the cortical material was removed, I performed the scleral sutures, and this is going to be the final result. So thank you.
Thank you, Dr. Lucas, for the wonderful presentation. What I liked about it is you did not extend the corneal incision itself. You let it be as it is, and you went ahead and you again did a proper scleral tunnel. So yes, that was very sensible and courageous of you. And I'm sure your patient would have been very, very happy because of that. And of course, later, if the incision can become more of a frown, then it can be astigmatically more neutral incision. But then a patient who has not seen for 5 years is going to be very, very happy after the surgery. Thank you.
Thank you.
Any questions for Dr. Lucas?
I have one suggestion for Dr.
Yep.
Lucas. Brilliant. I mean, you were able to implant intraocular lenses in these very difficult cases, but maybe one should not ever grasp the scleral, the lip of the sclera in the tunnel. That's the only mode. If you can stabilize the globe with the forceps and complete the tunnel, that's the only thing I would suggest. It's really lovely. Thank you.
Thank you.
Thank you. Thank you. Can we go on to our next speaker, Dr. Luisa Bicalho, who is from Belo Horizonte. I think that's the 3rd largest city in Brazil among the big 3. So, Dr. Luisa.
Hi, everyone. Good morning, good afternoon. I'm Luisa Bicalho. I'm I'm from Brazil. I'm Dr. Sergio Canabrava assistant. I was his assistant by that time. We performed this study, and he invited me to present this case for you guys. And so it's a new method of subluxated cataract management. It's called double flange technique. It's a preliminary report. Dr. Sergio has royalty agreements with Mandu Indian Instruments, and the other authors have no commercial interest. The purpose of the study was to describe a new sutureless technique for fixating the capsular bag in patients with zonular dialysis greater than 120 degrees undergoing cataract surgery. The technique used a 5.0 polypropylene suture and a capsular tension segment to fixate the subluxated capsular bag in the sclera using a flange method in both sides of the suture. Dr. Canabrava, he inspired this technique on Yamani sutureless sclerofixation technique. So here we have the materials that we need. We need one 5.0 polypropylene monofilament. We need one CTS and one CTR. We need one insulin needle and a portable cautery. So here I'll show you guys how to perform the technique. So in the first image, we can see he's making the sclerotomy at 2 millimeters from the limbus. Through the main incision with a microforceps, he inserts the monofilament inside to the needle with 9 degrees. And after that, you use the needle as a guide and you pull it out, the monofilament, through the sclera. Then in the another end of the monofilament, you insert this monofilament through the CTS eyelet and make the first flange. Once it's placed, you place it on the zonular weakness area inside to the bag, and then you cut the monofilament at 5 millimeters from the limbus. So now we are making the second flange. This is in figure E. On the last image, on figure F, you can see the complex. The bag is held by the CTS and the polypropylene monofilament. So here we have the real image, the real life image. Here on the first picture, he is inserting the CTR inside to the bag before I start the surgery. And then through the main incision, he passes the monofilament and insert inside to the needle. Use again the needle as a guide and pull it out through the sclera. Remember, the sclerotomy is 2 millimeters from the limbus. Once it's done, you make the first flange. You pass the monofilament through the eyelet of the CTS and heat it and shape it into a flange. Then you place the CTS in the zonular weakness area and pull it out, pull the monofilament out through the sclera, cut 5 millimeters from the limbus and heat and shape it into a flange again. And now you are making the second flange. Here, the last image, you can see the complex placed and everything is stable. So the method, the study design was a consecutive case series, a preliminary report that evaluated 14 eyes in 13 patients with zonular dialysis greater than 120 degrees undergoing cataract surgery. The study was performed at Santa Casa of Misericordia in Brazil. And we evaluate the stability of the sacral bag and IOL centralization. the possibility of scleral degradation and ocular infection. The follow-up was made with 6, 9, 12, 18, and 24 months post-operatory. In the 18 month, we did UBM and anterior segment OCT to evaluate these eyes. Here we have the analysis, the data. So we had 29% of patients of eyes with ocular trauma, 14% because of microspherophakia, 7% due to Marfan syndrome, 7% UV iris, and 43% post-phacoemulsification. Here you can see the follow-up, and by the end of the study, all the complex were stable. The study, there are some limitations in the study, and its lack of control group, a small sample size, and analysis was performed with different causes of zonular disinsertion. To conclude, the absence of suture, flaps, and glue makes it faster to perform, induces less trauma, and presents less steps in the learning curve. It also avoids complications associated with suture degradation and subsequent IOL dislocation over time. However, because it's a new technique, there is a necessity for further studies with more patients and a longer follow-up. Thank you very much.
Thank you, Dr. Louisa. It's a very novel and a simple technique. And well, you've done it from Madhu Instruments, but so many of us in India are still not aware of it. So thank you for making us more aware. May I request Dr. Nivian to make a comment on this, and then Dr. Sunil Singh.
Yes, sir. Yes, I think it's an excellent technique, but as all techniques, it takes a small learning curve to understand how the sutures are actually brought out. And I was fortunate enough to listen to Kanhora's talk also in the previous webinar, where he used the 4-flange technique to fix the foldable IOLs, the Bausch & Lomb plate haptic IOLs. So that publication was out, isn't it? So we are yet to try it out here. You people make it look simple. I think every technique has a learning curve. So it should be a good alternative, as you said, without the glue and the flaps. And also, as you said, we need a longer term followability for the stability and to see the erosions in the sclera. The main worry is other techniques have a long follow-up period. So I think that is one thing you have to.
Yeah, that's true. It's only time will tell if the lens is really stable, that it does not cause any astigmatism, and that in the long term there is no, decentration or subluxation.
Yes.
And then I would like to congratulate our Brazilian colleagues for really taking this up, and we hope to see a publication from you soon. So thank you, Dr. Nivian. Dr. Sanjay Singh, sir.
Dr. Sunil Singh, Parikshit, I think.
Sorry, Sunil Singh, sir.
Thank you, Parikshit, and thank you for the Brazilian counterparts for placing such a wonderful video and wonderful talk. In this particular thing, I mean, it's a longer, it's difficult to command, number one. And number two, the thing is that long-term thing, it's still to know that what will be the stability of the IOL. And I think that this technique might be proved to be very useful, but it's difficult to learn. And I think one should try it his wise. Suddenly, if some new surgeon tries it in one go to master it, I think it will be very difficult. It will be a stepwise process. But anyway, it's to be seen what is the real implication of these kind of surgery. But it's wonderful technique and a wonderful video. Thank you.
Thank you, Dr. Singh, sir. And of course, Dr. Singh is unique amongst us because he's not just an ophthalmologist, but he's very active in various social work and also in active politics. I mean, so I think your party has just won the election in Bihar. So congratulations.
Thank you, everyone.
With your vast experience, you will help make many changes in the way eye care is delivered in Bihar, which still remains, I mean, it has such glorious history, but there is so much more to be done there.
Sure, Parikshit. I think Bihar is looking forward to make changes in eye care. I think that this society, ISMCS, will also be helpful in formulating eye care policies in Bihar. And I hope hope the cooperation of this society also to the Bihar. that Bihar government will always be ready to encompass this in this eye care policy. Thank you, Parikshit.
Thank you. Thank you, Dr. Sunil Singh, sir. And thank you, Dr. Luzia. I think since we have a long list of speakers ahead, can we then go on to our own Indian speakers, starting from our chairman, Dr. Sahu, sir, who will be speaking on his 3 mm SICS. Can you share your screen, sir? Can you start the video, sir? Hello. Yes, sir. Parikshit.
If the voice is not heard, is there any commentary in this? Otherwise, you can speak.
Yeah, Sahu, sir, I think you can give the commentary yourself.
Yeah.
Well, Dr. Sahu is presenting his trademarked 3 millimeters manual small incision cataract surgery through the scleral tunnel. He's been a pioneer in this respect because earlier a 3 millimeter incision was usually associated only with phacoemulsification. Here, even though the external wound is 3 millimeters, the internal wound, like it there, the internal wound is more than 4.5 to 5 millimeters, but it is possible to have a manual SICS extraction even through such a small incision, as we will see soon.
Can you hear?
Yes, sir, we can hear you. Please go on with the commentary, sir.
Yeah, this is the rexis is in the routine manner. This is a bent 24 test needle, and with the left hand I am stabilizing the eye. So when you are proceeding ahead, you cut it. This is my modifier dialer, and this is one way of bringing out in the breaking the lens in the tunnel. Otherwise, I also break it in the entry chamber.
Sir, can we have the video full screen? Yeah, thank you.
So in the through the pocket you can put, or you can inject it also.
So would you like to make any more comment on this, sir?
You can put all kind of lenses, including the, toric IOL and multifocal, everything you can do with this. So result is very good. I will invite some questions if that is there.
Thank you, Dr. Sahu, sir. Till we have any questions, I would like also to welcome Dr. Devashish Bhattacharya, who is the president of our society, one of India's most eminent ophthalmic surgeons. Dr. Devashish, sir, would you like to make some comment?
Thank you, Parikshit. Sahu sir's technique has become a kind of doing cataract surgery through a small incision. And the only word of caution I would ask the younger surgeons to follow is to do a meticulous cleaning of, it's a phaco-fracture technique in the tunnel. So you have to clean the tunnel of the debris. Otherwise, you might get an irritable eye, which Sahu sir didn't show in the length of the video. But they must have realized that, it is important. And the second thing is, obviously, when you are fracturing the nucleus in the tunnel, be very sure that the other end of the nucleus doesn't touch the endothelium. So these are some words of caution. It might look very simple in an experienced hand, but there are certain tricks in every way of doing cataract surgery, and this is a wonderful technique. He's been doing it for ages with wonderful patient satisfaction. Thank you.
I have a multiple jet cannula which flushes out all the debris.
Exactly, which you forgot to mention. So I just passed the word of caution to the young people. Yeah.
By the way, Dada's son is getting married soon. So,
so I had some family ritual. I was a little late in joining. Sorry for the next part of the Brazilian part. I could hear. I was listening to my mobile phone a little bit. It were wonderful presentations. That's what I can say. It was very comprehensive, and they're very much into the SICS concept of what this brand of cataract surgery can do in the community at large. So I think we are on the same page.
Yeah.
To our Brazilian friends, Devashish Bhattacharya is the owner of Disha Eye Hospital, with whom we did the last World Conference, and that is a group of hospitals. He is the boss.
Yeah, he has perhaps the largest private practice in this part of the world. So,
and also a wonderful management man who tried to train most of the youngsters, not only in ophthalmology, but also how to be a good ophthalmologist overall. And he's also the president of ISMCS Society. Welcome, Dr. Devashish, sir. Welcome to this meeting. Thank you.
Thank you. So can we go on to our next speaker, our Vice Chairman, Dr. Jagannath Boramani, who will be presenting on how to modulate the incision so as to have minimal astigmatism. Over to you, Dr. Boramani, sir.
Yeah, can you hear me?
Oh, yes, sir. Yes, sir.
Yeah. And after this, we can have Dr. Satanshu giving us some tips on this.
Yeah.
Weaker in neutralizing the astigmatism.
Can you hear the voice commentary?
Incisions or
we can hear your voice.
Yeah.
The effect of superior nasal and superiotemporal incisions are in between the in case of superior straight incisions, the astigmatism.
Let me start from the beginning.
The presentation is to show how the astigmatism can be tackled by customizing the scleral incisions. In case of superior straight incisions, the astigmatism can be progressively reduced by reducing the size of the incision. The induced astigmatism can be progressively reduced by making the incision more and more curved. Compared to superior incisions, the temporal incisions are weaker in neutralizing the astigmatism. Temporal curved incisions are astigmatically almost neutral. The effect of superior nasal and superiotemporal incisions are in between the superior and temporal incisions. To To get a good effect of the vector forces, the incision should be centered on the steep meridian. To minimize errors, I mark the horizontal and vertical meridian in patient's sitting position. Once the patient is on table, the steep meridian is marked on the cornea and the incision is centered on the steep meridian. Here are few pre-operative and post-operative corneal topographies. The post-operative topography is done approximately 20 days after surgery. The type of the incision is shown between the two topographies. Here, with a moderately curved incision, 0.39 diopters of astigmatism is reduced to 0.22 diopters. Here, the vertical meridian is steep. A 1.12 diopters of astigmatism is reduced to 0.15 diopters with a straight incision. A straight temporal incision significantly reduces astigmatism of 1.24 diopters. This is a case of multifocal IOL. The astigmatism is insignificant and is slightly reduced further. This is a case of high astigmatism of 3.3 diopters. The astigmatism was significantly reduced with a straight incision without using a toric IOL. This becomes a premium surgery without using a premium IOL. Now I use the term surgically corrected astigmatism instead of using the term surgically induced astigmatism. Let us call this as CICS, customized incision cataract surgery. With customized, it is possible to wipe out or at least minimize the stigma of astigmatism. Thank you very much.
Thank you, Dr. Boramani, for that wonderful presentation, as always. And you always tell us new ways to take care of astigmatism. Dr. Satanshu Mathur, sir, would you like to comment on this? Well, I think he's not there. And even Dr. Rajiv Raut, I'm trying to get in touch with him. Yes, Dr. Nanda, please.
Yeah, I just wanted to know if a patient has a neutral astigmatism before surgery. So what would be the best option? The patient has a deep socketed eye and a neutral astigmatism, or maybe against the rule astigmatism, then what is to be done?
If it is a neutral astigmatism, if you don't want to induce astigmatism, you better have a U-shaped incision superiotemporally, or go more superiotemporally, because you get access to the eyeball, because it is a deep socket eyeball. And you can operate from superiotemporal and U-shaped. The periphery extensions of the incision can go up to 4 millimeter if you are very much away from the limbus. Still, it will not induce any astigmatism. Maybe the central curved part can be a 2 millimeter very close to the limbus, as Dr. Sahu's incision also. It will not induce any astigmatism. So depending upon the pre-existing astigmatism, you have to modify the shape and the distance from the limbus, as well as the length of the incision. So accordingly, you can customize the incisions.
Thank you.
Thank you. Thank you, Dr. Nanda, for that pertinent question. And well, Dr. Boramani is now the executive chairman of ISMS-ICS. He's the one who is our leader, who has just taken over the baton from Dr. Sahu to take ISMS-ICS further. And now we have this link up with Brazil. So till we don't have...
Dr. Devashish's comments.
Yes, sir.
Yeah, no, I just wanted to add a comment to the intelligent question posted by Ashok Nanda, who says, I mean, what happens if the patient is astigmatically neutral? Well, any incision, Dr. Boramani would agree, would give around a 0.5 astigmatism. So we would prefer a minus 0.5 cylinder 90. That is a good, SIA, not the surgically controlled astigmatism, but the surgically induced astigmatism. I think that we all intelligently follow. So it has to be a superior incision and up frown, yes.
Correct. This is absolutely correct. But the same methodology can be used. Like say patient is astigmatic neutral and he want, especially this is more so for illiterate patients. They are more happy with some astigmatism. So you can use the same algorithm to induce about 0.5 diopters of astigmatism. But I showed a case where the patient had underwent a multifocal IOL implantation. So in that case, that astigmatism is not necessary. So you don't induce any astigmatism in such case.
Yeah, absolutely. Absolutely.
Thank you. Thank you, Dr. Bhattacharya, sir. May I now ask Dr. Manisha Rathi to present on Chevron incision of frown. And I would like to remind the speakers that it was 3 minutes. I know that is small, but we would like to keep it as brief as possible.
I'll just start my screen sharing.
Sure, ma'am.
I just checked it before this. Yeah. So as the other. Oh yeah, right.
Parikshit, tell few words about her. She is the HOD.
Yes, I think let's hear her first and then we make the introduction, sir.
Good evening, greetings. I'm from Haryana, India, and I have been doing SICS since 2000, and now I realize I have to learn so much more. The incision is very important. We get poor patients with hard cataracts who present late. Therefore, we have to have a wide chevron or frown incision. Affordability is an issue, so we are implanting in these patients rigid intraocular lenses. As you can see, you have to swipe side by side. Do not over-cauterize, get good exposure, swipe, then swivel with the crease. And these are all disposable, inexpensive instruments. You should be, the main thing is keep away from the cornea, at least 1.5 millimeters from the limbus and 50 to 75%. As you can see the crescent knife throughout the surgery and throughout the length of the tunnel in one plane. It should be in one plane, not premature, not deep. Because of paucity of time, I'm showing several incisions. As you can see, we've measured this and shown you 3.5, 7 millimeters. This is another patient, so we've made it a modified chevron, even with a hard cataract. And we've done a study in which with the chevron, the average post-operative surgical induced astigmatism was 0.5 diopters. As you can see, again, the similar configuration of the tunnel. In all these cases, we did a CCC and we implanted rigid intraocular lenses. So the cost of surgery was less than $10 US. This is an 80-year-old patient with a hard cataract. Now you might think the 7 millimeter is a wide incision, but you will see in this case, I'll show the CCC and nucleus delivery. The nucleus could just be coaxed out of this tunnel. So initially I used to do through a side port because we have this large tunnel. So what I do is I start with a needle and then I complete with the forceps because it gives a very good grip. And in almost all these cases, we are able to do a CCC, even in the phacomorphic glaucomas, intumescent cataracts, Morgagnian cataracts, we have managed to complete the CCC. It's always good to have an intact capsular bag. Now you see this nucleus through this tunnel of 7 millimeters, I can just about get it through. So this is the configuration of the patient. Again, another rigid intraocular lens has been implanted. Over the past decade, we have seen that the chevron incision has proved superior. In the softer cataracts, we make a steep chevron of 5 millimeter chord length. So you can see all these studies in 2013, 15, 20, and our own study that the chevron is superior to the frown incision. But the main thing is keep away from the limbus. Do not over-cauterize and do a CCC in all your cases. This patient, this was the hard cataract in the other eye. She said, might as well do this eye also of mine because I might not come back later. So this is a softer cataract. And in this patient, they brought an indigenous foldable intraocular lens. Not pretty expensive, but still more expensive. This lady wanted a picture because her whole family was operated on by me. So I'm very grateful, humbled, and I really have a lot to learn to do better for these patients. Thank you so much. Thank you, sir.
Thank you, doctor, for such a short yet such a succinct and useful presentation. And I think you also have a lot to teach, ma'am, if you have been doing it for past 20 years and you have so many publications.
We are very lucky to have postgraduate students. We have 30 postgraduate students. Wow. So most of them have, and doing it under Topical. So most of them have graduated to become leading ophthalmic surgeons in the vicinity and abroad. And we are very blessed to have this opportunity to teach them. And of course, you have to keep evolving. Now we have to learn Dr. Sahu sir's and Dr. Boramani's technique. So there's a long road ahead.
No, thank you. And thank you for joining with ISMS ICS. And I'm sure we'll be hearing more from you and reading more from you. I would also request Dr. Sunil Thangarajan to make a quick comment before we ask our next speaker, Dr. Sundaram Shetty, to be ready.
I mean, that was a wonderful presentation. There's nothing, I mean, this is a standard incision. She has done it so well. And many times we forget we are competing with phaco. I think SICS is a surgery by itself, and sometimes we only concentrate on the astigmatism, astigmatism part of it. So phaco is better just because of the astigmatism. But if you actually look at it, SICS, at least in the beginning surgeon or in the less experienced surgeon, it's a much easier surgery to learn. They have less complications, they get more confidence, and it can be used for a variety of situations, and you get the similar results. You get exactly the similar results. Doesn't matter whether it's soft, doesn't matter whether it's hard. If you actually take your post-op pictures the next day, people may say the hard cataract and phaco, you do get pristine corneas, but does not always happen. But in SICS, it always happens.
I realize post-op pictures are very important. So I had a lot of them, but because of the 3-minute thing, I'm not showing. But you're so right. And the rigidity. See, if a patient can only afford a 200 rupee lens, this with a 6.5 millimeter optic, this is the only choice. So we might as well make it a good incision and follow up. We just can't sit happy that, okay, we've done this white cataract. You have to see the keratometry. So we've done over 6 months the keratometry and then come to the conclusion, and then we have to improve more. Thank you, Dr. Sunil. Thank you so much.
No, I mean, your smiling patient says everything, ma'am. That the smile on the patient's face is, I mean, that's the best reward.
She borrowed a phone from her grandson that I want that picture with you. So thank you so much.
Yeah, thank you. Thank you for joining with us, and please stay with us. I would now request Dr. Sundaram Shetty to present SICS without the corneal pocket. And thank you, Dr. Thangarajan, sir, for that very lovely comment. Yes, that cataracts are different and different cataracts need different techniques. Thank you. So we cannot hear you, sir.
Yeah, I'm coming.
Yeah. Thank you.
Can you hear me now?
Dr. Sundar, sir. Yeah. We can hear you now, sir.
I will play from the beginning. This is a video showing doing a cataract SICS using a 6 mm wide and 3 mm long in the center with the 2 parallel pillars, which is astigmatic neutral, and doing only the scleral pocket first and doing the corneal part of the tunnel using the sharp keratome directly. So I use the crescent blade to make the peritomy, and I mainly do the scleral part of the pocket using the same crescent blade, and enter the entry chamber on the floor of the tunnel using an irrigating cystitome. I do the capsulotomy under the BSS or ringer lactate. And this tunnel is located in the superior temporal quadrant, 1.5 millimeter on either side of the mid-limbal line. It is 3 millimeter wide, long in the center. Do the side port, which is volvular, and then watch the inner entry, which is much beyond the pocket. It is entering in the clear cornea, which is unsplit. Very important, it is a smile inner cut, which is parallel to the mid-limbal line, so that we get a biconcave shaped tunnel, which is astigmatic neutral, meaning 0.5 or less astigmatism. And this tunnel can be widened when, if you want to, with keeping the architecture or the design same, can make it 6 or 7 or 8 mm. I prefer to do a 6 mm tunnel so that I will not lose the advantage of using the rigid lens. This is, I bisect the nucleus using the vectis and the dialer, and into 2 pieces, which will easily pass through this 6 mm tunnel without stretching the tunnel. and use the visco generously to keep the cornea away, endothelium away from the nuclear pieces. I first remove the cortex which is under the side port, and rest of the cortex I try and remove from the side port, so that I will have a closed chamber effect and the deep entry chamber, and the posterior capsule is far away from the aspirating port. Once it's all clean up, I have the advantage of using the rigid lens as usual and close the complete the surgery. And this tunnel is hard rock in a sense. It doesn't budge, and it gives you minimum astigmatism, as Debashis sir said, plus or minus 0.5. You can count on that. More than 100,000 surgeries are done using this technique. Thank you very much.
Thank you, sir. 100,000 surgeries is a lot of surgeries, sir.
Yeah, we run an NGO which is called Global Foundation. So for the last 25 years, so we have a huge volume of patients being operated, and we have crossed 100,000 surgeries 2 months back.
Wow, so that's a big milestone. Congratulations for that, sir.
Thank you, sir.
And are they all manual SICS, or are they, some of them are ECC or some of them are phaco? How is it?
ECC probably first we started in 1995-96. So maybe first 2 or 3 years. Ours was the first hospital to start train the doctors in SICS way back in 97, 98. We have got more than 200 surgeons, Karnataka and all over India actually, who have come down and got trained with us. And this, we have a huge, volume of cases wherein we have used this tunnel and got absolutely good control of the astigmatism. And those fellows who are trained under us are very grateful to us for teaching this technique. So it's quite popular in Karnataka. I don't know elsewhere.
Thank you, Dr. Sundaram Shetty, sir. For that, again, short and sweet presentation. Now, I would request another very senior gentleman from Karnataka, Dr. M.S. Ravindran, who will be speaking on topical limbal incision, MSICS. Dr. Ravindran is an iconic surgeon, both for SICS and phaco, and he does not need any introduction. Till he's uploading his presentation, would Dr. Deepak Mishra make a quick comment on Dr. Shetty's presentation? I think we can start then, Ravindran, sir.
I'll quickly show a couple of surgeries that I currently practice. That's an entry with a keratome on the anterior sclera. It travels across the limbus into the cornea and dips inside and goes back. Most important is to see that the anterior incision and posterior incision are parallel to each other. Now, tunnel floor entry technique is where the cystotome enters not through the tunnel, but through the floor of the tunnel, goes inside. Through the initial tunnel, I have filled the chamber with viscoelastic so that it's tight and nice. Because of the tunnel floor entry technique, there is no leak of visco across the tunnel. So you can have a deep chamber throughout, especially for beginners, it's of great use. If you can't pierce the floor at the limbus, that's the entry point with the needle, you can actually make a small MBR entry and then you can go through that. That keeps the tunnel very tight. Now it's enlarged. Again, ensure that the anterior end and posterior end are parallel to each other. It's a rectangle. There's no flare on either side. Hydrodissection is done with a very special cannula, which is short and at 45 degrees. Rotate the nucleus just by 1 clock hour or 2 clock hours and prolapse the nucleus as well as epinucleus into the anterior chamber. A 25 gauge cannula, which is continuously injecting visco to protect the endothelium, is enough to bisect most of the nuclei. And if it is a thick, hard nuclei, you can use the cystotome itself to score and bisect the nucleus. and I'll run it faster. Remove the cortex, and then as there is no side port, there is a single port. You need a 12 o'clock cannulas to do that. And again, my technique of injection is very simple. Soak it, coat it with visco completely so that it doesn't stick. Fold it just like a classical one. Instead of using injector, I use a simple rod, a 16 gauge rod to push it inside through the cartridge. You don't need an injector. Goes inside. The advantage is the lens is not folded like what you normally see. You see this? It is slit on the top. It's slit mechanically on the top, so it widens up inside the eye so that it's not compressed. So it's a very elegant technique. I would like to present it in another case. It's an anophthalmos case. The axial length is 5.9 millimeters. The power of lens the patient needs is 60 diopters, 60. I could manufacture one lens or a PMMA of 60 diopters, as you can see here. Similar technique is used. This is a 28-year-old lady who was wearing contact lenses and on the top of it, plus 10 or plus 12 glasses. And that's the lens which is specially designed. It's a 5.5 millimeter lens, and the corneal diameter is 9.5, and the overall length is also less, 11.5. We designed it here, and a single lens, and the formulas worked beautifully well, and she needed minus 0.75 glasses at the end. There's another beautiful technique for very hard cataracts. It's a snare which is designed by Dr. Shah, who is going to present his topic. I like this, and it bisects it beautifully. Only thing is you'll have to protect the endothelium continuously, and each piece could be taken it out with, he takes it out, Dr. Shah takes it out with Foster's, but I would like to, this is my habit of taking it out. And the other very good technique that is possible with incision is, instead of fixing the lenses into the sclera, you can comfortably, in 2 minutes time, you can fix a lens called the iris fixation lens. That's a 27 gauge cannula ready to enclavate. I hold it there, take it behind the iris, and just lift the lens up and push this behind, and you can see it's enclaved. It's a very quick technique, especially when you lost your posterior capsule, or when this is a case which has got nystagmus, topical anesthesia, and you hold it. Pupil should be about 3.5 millimeters when you're doing it. It's a very small lens. Lift it up, and a cannula, 27 gauge cannula is ideal, and pupil remains round. You can continue with vitrectomy. You can go beyond the edge of the lens, and that's another elegant technique that you can master when you're doing SICS. Thank you very much.
Thank you, Dr. Ravindran. You have always been, what shall we say, customized or tailored cataract surgery, because nowadays cataract surgery is like hamburgers. It is very standardized, but for different situations you actually not just tailor the incision, but tailor the lens, tailor the scan. So that's a message for all our youngsters and all our viewers abroad, that each eye is different, each cataract is different, and finally we have to give the best possible vision to the patient. I think we'll quickly do the next two presenters because we are slightly short on time, and then we can have more of interactions. So now I would like to invite Dr. Pratyush Ranjan, our young, now well not so young, but a very versatile and a very prolific surgeon from Uttar Pradesh. And he has his own Ranjan marker to minimize astigmatism. And now he'll be speaking on the trans-conjunctival manual SICS. Over to you, Dr. Pratyush, sir.
Yes.
There he is. Yes, Dr. Pratyush, please.
Yeah, I'm having little trouble in sharing.
You have shared yourself.
Your screen had come once. Try again.
till that time, you let the other speaker come.
Yeah, that would be, I think.
Parikshit?
Yeah. Who is the next speaker? I think Dr. Anil Shah is remaining.
Sorry, I'm here.
Yes,
Shah and Dr.
Yes,
Saurabh Patwardhan, both of them.
Saurabh Patwardhan,
So
correct.
I think we can give a last try, Dr. Pratyush.
Yeah, or perhaps, yeah, if not, then someone else and then he does it again.
Yeah.
Yeah, please allow someone else to continue. I think I'm a little stuck.
Okay, fine.
I was not trying. I think I have got it. Yeah. I think this video is visible.
Yeah, video is visible.
Please go ahead.
Yeah, hi, I'm from Varanasi, the oldest living city in the world. And this is my technique of SICS, the trans-conjunctival, using a Ranjan SICS marker, and it is topical. So, one direct incision which cuts both the conjunctiva and the sclera together, and this Ranjan marker with the serrated edges in the back holds the globe in the place, and this is a topical cataract surgery, mind it. The usual tunnel making.
Use the sound of breathing.
The rexus using a utrata forceps from the side port. Now I'm entering the anterior chamber. The half tunnel was made that time. Now entering, putting the descents, making the pockets. Hydro and trying to pop out the nucleus at the same time. If the nucleus is big, I use hitting forceps. Otherwise, this whisper expression or hydro expression is also enough. Now the bag is cleaned using Simco. And once the bag is cleaned, I implant under hydro with Simco from the side port and lens from the main port. Closing it with the hydro of the side port. And for the conjunctiva, I do a cautery, a tag cautery, what I call it. I just tag the edges of conjunctiva. So you can just 2-3 tags will just close it, and next day morning the patient is absolutely fine. This is pre-op. And post-op, just on day 1. That's it. I think if you have any questions, I would be able to answer.
Dr. Ranjan, this is really good. And especially when people start and they wonder how to make the tunnel, and they're making all kinds of squiggles and everything on this thing, which we prevent them from. You have to hold their hand and make a tunnel. This is very useful. So where can we buy this?
Thank you. Then this is from Epsilon. Epsilon, I'll share the number on this or on WhatsApp group. I'll share the number on the WhatsApp group.
Thank you, sir.
Pratyush, and Epsilon, they developed it. Their development team is at US, and they are also supplying all over the world.
What I would suggest to them is first they make the conjunctival flap, and then they can use it on the sclera also. Because
yes, it can be done. It can be done.
If they just touch the cautery on the scleral lip, that will cause problems and more astigmatism and all. So initially they can, I think, start like that.
Yes. One small story I just want to share, because once I got associated with Dr. Sahu, and he was very inspiring and encouraging surgeon. So once I was watching one of those videos, and where Dr. Devasis was using a topical SICS, and I was like shocked how to do a topical SICS. So I went back and tried, but I could not hold that eye. So I asked Dr. Devasis on the next meet. Then he said, try Epsilon 0.2 mm limbal forceps, and it really worked, but still it was tearing. So then one fine morning I got an idea just to develop something which holds it 360 degree, and that gives a better hold.
And our first topical SICS long ago was by default, because that patient did not respond to a peribulbar block at all. So she was squeezing, moving. So we said, let's try to do this, with great caution. Then he realized that was long ago. So then he realized the topical is, but except for uncooperative patients who are very anxious and keep trying to squeeze, we still give a peribulbar.
Yeah. So my SICS, I thank Dr. Devasis and Dr. Amulya Sahu and ISMSI's team to encourage me. Otherwise, that was a great mental block. I never thought I could do topical SICS.
No, I mean, the forceps in your left hand should be the second instrument, like the chopper in phacoemulsification. Like when you are doing an incision, so the counter force should be on the forceps. So if you are giving the incision here, your forceps should go the other way around. So it's like the two playing in symphony for anything that you do. When you are taking the nucleus out, you take the eye down, you engage the nucleus with the vectis as Pratyush did, and then depress the posterior lip, and you come up with the forceps, depress the posterior lip, and the nucleus comes out. So, I mean, the forceps is probably a very malleable second-hand instrument in the whole process. Yes.
Okay. Thank you, Devasis sir. Thank you, Dr. Pratyush. It was an excellent presentation, and the video you showed was of great, excellent quality as well. Thank you very much. We have a few more discussions, and the end of the two more talks we have is now we have next Master Blaster from Sangli, Dr. Saurabh Patwardhan, Director of Nandadeep Eye Hospitals and PG Institutes. He's Head of FACO SICS Training. He's the Chief Mentor of the FACO Tips 3D teaching course. That's one of the first of its kind in the world. And he is also very pioneer. He's a very enthusiastic man, pioneer in live streaming on surgeries on YouTube and Facebook for educational, more than 10 publications and 30 chapters in various books, journals. And he's also the inventor of iToric Patwardhan. That's the Android-based, phone-based toric marking. And he has, to his credit, of more than 30,000 surgeries with specialties in various fields. He was actually, I was thought him to be a retina person, but he ran away and started becoming a cataract surgeon nowadays. And he's an invited faculty in many national and international. Over to Dr. Saurabh Patwardhan, sir, and we thank him for being an instrumental in forming the ISM-SICS Brazil chapter. He has played an instrumental role along with the invention of his instruments. Thank you very much, Dr. Saurabh. Over to you, please.
Thank you, Dr. Srinivas. He's like brother to me. And thank you, Dr. Sahu and Dr. Nito, because of their enthusiasm, this chapter has come into reality. And welcome to all the members from Brazil. And I'll be sharing a brief video about traumatic cataract. It is a subluxated cataract. So let me start sharing the video. Now this was a case of a subluxated traumatic cataract, and what is different here is that apart from the large 6 cloaca subluxation is that it's a dense cataract with fibrosed anterior capsule. And for taking care of this subluxated cataract, for fixing it to the bag, a good CCC is must. So I think the first challenge here is to create a continuous curvilinear capsulorhexis. So I'm using a bimanual method here because the fibrosed area, the capsulorhexis was not progressing, so I have to use a cystitome to cut the fibrosis and pull the capsulorhexis further, and thus I could achieve capsulorhexis, but I'm not sure about the integrity. Then I used capsular hooks. I think for all subluxated cataract, capsular hooks have to be used, and I decided to go for SICS in this case because I was not sure of the CCC integrity. So I said I will better remove the dense nucleus by small incision cataract surgery, and it's important to avoid AC collapse in these cases to avoid vitreous prolapse. After this, I'm implanting a capsular tension ring, and because I was unsure of the CCC integrity, I have threaded a 10-0 nylon. I think this is a good trick to have through the eyelet, so that in case the CTR refuses to stay in the bag and instead starts going into the vitreous, I can always retrieve it back by pulling the 10-0 nylon. And once I'm sure that it is now supporting the bag well and inside the bag, I removed that 10-0 nylon, and now I'm going to fix the bag to the sclera because this is a 6 cloaca subluxation. I'll be using a CT segment, capsular tension segment, and using 9-0 Prolene to fix it to the sclera. Thus I could achieve a well-centered bag, and I used a large optic PMMA lens in the bag, and you can see the post-operative period with very good visual outcome. Thank you so much. That was from me. I think for subluxated cataract, I think SICS is a good technique to have because it is the original low IOP surgery, which nowadays phaco machines are trying to mimic. But I think the low IOP during surgery will help in cases where you want the pressure in the anterior chamber not to rise. So I think it's the technique that everyone should master.
Thank you, Dr. Saurabh. Dr. Meeta Joshi is here. Dr. Meeta, you want to add a few comments, madam? You are muted.
Very well done surgery. And I think the tissue handling was excellent in this case because the fibrosed capsule would have otherwise been a nightmare. So doing it two-handed using both the hands and the cystitome and cutting it round would be a very good tip for all surgeons.
Dr. Saurabh, sir, I had a question. Till what degrees of subluxation do you still try CTR? And if it is more than 270 degrees or only a few degrees of it is left, and what is your choice of surgery next? And what kind of scleral fixated IOL you would like to prefer for these cases?
Okay, for subluxation, I think we have to first decide whether it is because of localized zonular weakness or it is a generalized. Like for example, PXF, you have more weakness than what you actually see. So in generalized zonular weakness, it is better to fix the back irrespective of the size of subluxation. But with traumatic cataracts, even up to 3 or 4 cloacas, we can just get away just putting the CTR. But more than that, it is better to fix it to the sclera using a CT segment or Sioni ring. But I think more than 6 cloacas, it depends on surgeon's preference. You can fix the bag to the sclera. That is one option, but it's better in the long run if the zonular weakness is generalized, like in case of PXF, it is better, or like Marfan's, where it is going to increase over a period of time, to remove the lens in toto and put a scleral fixated IOL, either by standard technique of intrascleral fixation or Yamane's technique.
So what is your preferred choice of using the CTR, whether you want to do it manually or you like to use an injector for the CTRs?
CTR, I have learned it to do it manually, but I'm sure the using injector is also a good idea.
Dr. Nivian, you would like to prefer the same using the injector, or would like to have it manually, the CTR?
I sometimes for the fold will prefer the injector, because sometimes these lenses fold, and getting the initial haptic into the bag, I think we got used to the phaco, so that helps. But I also should say I'm a big fan of Saurabh's YouTube channel. I think he got a lot of interesting videos and excellent quality videos, isn't it? That's one more thing.
We can have two quick comments from MS Ravindra sir and Dr. Nito, and then we can go in for the next speaker.
Dr. Srinivas, I want to know from you how many of CTRs and dislocated capsular bags you have removed, being a vitreous refractive surgery.
Yeah.
The reason is when everybody were implanting them, I had a lot of referrals for removal of dislocated CTR with the bag and with the lens. They were all in vitreous cavity. I removed at least half a dozen of them over a period of 2 years, beginning. So my approach right now, if there is a subluxation, whatever may be the reason, more than 3 clock hours, less than 3 clock hours, I'll manage with implanting the lens itself without the CTR. I'm very comfortable with them. And if it is more than that, I would tend to remove the cataract and remove the capsular bag and keep the hyaloidal phase. And I would like to put a retro iris implant without disturbing the pars plana. I want your comments on this. And we analyzed all our patients, the hundreds of them, of retro iris fixation lenses. There's no CME. See, the worry is that capsular bag is protecting the posterior segment from getting a CME. I think it's a false notion. I would appreciate if you can comment on this.
Yeah, I think I agree with MS Ravindra sir. Yes, we have removed quite a bit of CTRs, but most of the time I have seen is they're actually safely locating and not causing much of any traction on the retina. Unlike these IOLs, especially in the liquefied vitreous, where the CTR or the IOL keeps hanging or they keeps floating in the vitreous, that is most dangerous. In fact, in the intact gel, I still usually keep watching those patients rather than doing the surgery if the IOL is slightly placed in place. But coming to the next question on the retro iris, sir, I have a few reservations on these retro iris. Although we have done a study comparing 100 SF IOLs sutured or using the tracking system and trying to externalize the haptic and put it in the tunnel. But I have seen that these retro iris fixation, they develop iris atrophy. And I have seen a lot of dislodgements happening over the time, not initially, but I think after 5 years or 10 years. Of course, if you take the sutured SF IOLs also, they might disintegrate. I do not disagree with that. But when they have any posterior segment complications, like when they need any silicone oil or the gas, I have seen this, the gas or any tamponating agent shifting to AC in the places where there are retro iris fixated. And in fact, if you place a SF IOL with the sutures, it creates like a diaphragm, which will not allow any of the posterior segment tamponating agents to come into the AC. That's again my quick observations. Of course, all the panelists are here, experts are here. We can have a big debate topic on whether it needs to be a retrofixated or as SF IOL.
The only point I would like to say is most of the retro iris fixation was being done with iris hooks, where iris hook goes and damages the iris. So I shifted to the cannula. 27 gauge cannula is what we use. It's totally atraumatic, and it doesn't damage the pupil. And the diameter of the lens is as much as diameter of the retro scleral fixation lens, about 5 or 6 millimeter, whatever it is. And the obstruction it provides to the pupil for the silicone oil or gas to come forward is not much. Maybe you can try another go with modern technique of retro iris fixation. That's my.
We will take that point. The only thing which was worrying was the iris atrophy ensuing in the later stages. But definitely, it's a good point to be considered, and definitely whichever best suits in any surgeon's hand and what is best to the patient, I think is what best needs to be followed. Quickly to Dr. Nito. Yeah, yes, Dr. Saurabh.
Yeah, I think Srinivas, I think everyone understands that the bag is the best place for the IOL. and anything other than that is a acceptable compromise. So you have to decide which technique suits your surgical skill, and just focus on that technique, and over a period you will find that if you continue doing that particular technique, you master that, and your results are better than any other surgeon.
Quickly, we have one word comment from Debashish sir and Dr. Nito, please.
No, Saurabh is right, because these are not, for Srinivas, it might be bread and butter, but for the anterior segment surgeons, you do a traumatic cataract or a grossly subluxated cataract once in a while. So you fix on one technique, as MS Ravindra also pointed out, that he also gave away the enclavation Irish hook and took to the cannula. So you perfect that particular technique. If you enclavate well, yes, the iris fixated lenses do as well. But our institution, I think we go by the external scleral fixated IOLs since 2006, and they have really helped, these lenses going down, even compared to the sutured scleral fixated IOLs.
Yes, I agree with that, because both of them have, over the long-term studies are actually needed. And I think we can, through ISMSICS Society, we can join the various people and try to have a long-term effects, especially for 5 years and 10 years. That's where we need to know how this iris behaves in the retro iris fixated and the suture behaves in the SFIOLs. Yes, quickly, Dr. Nito.
Well, congratulations, Saurabh, for the wonderful presentation again. And you're a master surgeon, and we have a lot to learn from you. I think one of the important aspects to call attention from the presentation is that the surgeon should be prepared with devices or be able to perform techniques that may come handy when dealing with complicated or unexpected situations in surgery. And one must use whatever technique he is more proficient in doing. A recent study showed that of the many IOL fixation techniques available, almost all of them came out with comparable results over in the long-term aspect. So I think much of the surgeon choice is important to decide which technique to use. And I would only comment, in Brazil we have a lot of difficulty with many devices because of regulating agencies from my country. So we don't have many things available here. Things come very expensive, and there is no market to buy them here. And so the providers are not interested in selling them here because the volume would be so low. So we are very limited in options. For example, I would like very much to have iris claw, more iris claw IOLs options here, but we don't have. The only one we have is too much expensive for our population. So I think every technique should be learned from the surgeon to be able to choose the best he think is more appropriate to the case and for his skill, for example.
Thank you, Dr. Nito. I think we have a last presentation, and then I'd like to hear more from Dr. Sunil Thangarajan as well. After now comes the Snare man from India, is none other than Dr. Anil Shah. Sir, he's from Suryakanta Dolyanche Hospital in Nandurbar in Maharashtra. He has received various awards. You can start your screen share, sir, by the time I introduce you, because the pages runs more and more as I start introducing Dr. Anil Shah. He has received a research award from Maharashtra Ophthalmic Society for development of Snare for MSICS, and also for development of large foldable IOL for MSICS, and also for the development of modified intracystic implement for DCR. He has published various textbooks as well. That is the best out of waste, the manual phaco on MSICS and Master's Guide, Oculoplasty Made Easy. And he has given a lot of presentations on national and international platforms. With this few words, I request Dr. Anil Shah, sir, to please start his presentation.
So he is the first man to promote Snare. My loop came much after that. My loop, which is marketed more, is a take up on his ideas.
That's why I called him as the Snare man from India, sir.
Yeah.
Go to Dr. Anil Shah, please.
We learned our snare technique through Anil Shah. And obviously, I mean, it's a wonderful technique, just waiting for this video to come up. Yes.
Thank you, sir, everyone. Thanks for calling me in this Brazil chapter. I would like to share my video. Sir, where is video is visible?
No, sir. You have to share screen first.
Okay.
This is the last presentation, and after that, we'll have some more panel discussion, and then there we call it a night and a day for Brazil.
Is it visible now, sir?
Yes, sir. Yes, sir. Go ahead.
I'll go from the beginning, sir.
Yes, sir.
This is my snare, which you can make. This is do-it-yourself snare. It's very simple, and you can make it on your own. This is supra hard cataract, grade 4 black cataract, which it can easily divide with the snare. You can make 2 sections, bisections or trisections with this, and you can remove hardest cataract. This is the only single instrument that can be used for any grade of cataract, and it can be used to a smallest incision up to 3.5 millimeter. Here I am showing you up to 4.5 millimeter. The nucleus is divided into 3 pieces, and after the division, each nucleus is separated. And my preferred choice of removing is with the McPherson forceps. This is a thin, long McPherson forceps, which is available with any surgical company. I don't prefer Victis because Victis is too thick in this type of surgery. So with the thin McPherson forceps, I am removing this super hard cataract into 3 pieces. I have been doing SICS since 1990, more than 20 years I am doing SICS, and I have done more than 10,000 surgeries with this method. And to be very frank to tell you, when I was doing SICS, I had no PCR for last 10 years. But when I did FECO, I had 4 PCR and 2 nucleus drop. So I again shifted to this my previous technique of SICS doing by Snare, and I think it is one of the safest and comfortable techniques which can be applied to any grade of cataract, and the same technique is mastered for all grade of cataract, so you need not have to change your technique for each and every type of cataract. So this is another grade 4 cataract. The loop size can be adjusted according to the size of the nucleus, and you can divide hardest nucleus. Main important thing is that nucleus should be free floating into the anterior chamber. There should not be any attachment to endothelium, iris or posterior capsule. When the nucleus is free floating, when there is hypotony, you can easily do bisection, trisection and remove it with the forceps. It is absolutely simple, safe. Next day you get a very bright, clear cornea, and you can remove it through 3.5 millimeter, also the hardest cataract. But I am usually taking 4.5 millimeter incision for the sake of convenience. This is the last fragment which is removed, and routine irrigation, aspiration, and implantation of the lens is done. See, this is a thin, long McPherson forceps I am using for removing the cataract. Thank you very much, sir. Any comments, sir?
Yeah, thank you, sir. It was a wonderful presentation, sir. I had you can just stop your screen share.
Yes.
Yeah, sir. Till what grade of cataract is it? From grade 4 and grade 5, or can we use it in the slightly milder grade like grade 3 as well to decrease the size of the incision?
Yes, grade 3 also you can use it. Routinely now grade 3 cases are commonly done because hard cases are now less, but you can do in grade 3 cataract also.
So in any grade 3 cataracts, do you prefer using Snare in all the cases, sir?
Yes, sir. Snare already. Because I like to practice one method for all type of surgery. So I don't want to change the method. So this is a method which can be applied to any grade of cataract, from grade 2, grade 4 or super hard cataract. So I prefer Snare only. And there is no damage to endothelium or no damage to posterior capsule. everyone has got a fear that we will damage endothelium or we will damage posterior capsule. But many other techniques like phaco, vectis, or any other sandwich technique, they have damaged endothelium and they have damaged posterior capsule also. So there is nothing actually more, snare is more traumatic, but snare is actually more safe than any other method.
Sir, one quick question before we move on to Dr. Sunil Thangarajan. Can we just do it like a my-loop technique, how they do it in the bag? Can we use the snare to try to do it in the bag?
Sir, it is very difficult because my-loop technique is in the bag fragmentation of nucleus.
Yes.
Where the my-loop is remain inside and the needle goes to the nucleus.
Srinivas, can I come in? Yeah.
Yes, sir. Yes, sir. Please.
There are two limitations of my loop. One is because it uses Nitilon, it cannot deal with very hard cataracts. That's number one. And number two, as Anil Shah rightly pointed out, that the my loop actually comes out from the side. Actually, it's preloaded. I mean, it comes out from the side of the tip. So it comes out, whereas Dr. Anil Shah's snare is just a loop, which is, since I'm in the Brazilian group, let us say this Dr. Anil Shah's loop is made from the A1 string of the guitar, of the Spanish guitar or the Portuguese guitar. So that A1 string is threaded into two 20 gauge needles. So one 20 gauge needle is actually, the tip is blunted and the sides are made into hubs, and then the loop is created. And so and then it comes out through the hub of the needle, and then you take a second needle and put the free end of the wire into the second loop. So when you are actually pulling the second needle, you are closing the loop, and when you are pushing it, you are opening the loop. And another thing is because, Anil divided the nucleus into 3 parts. Now, if you are dividing it in only 2 parts, then you need the entire thickness of the nucleus to be engaged. So in that case, if the nucleus is 4 millimeters thick, so the loop will also be 4 millimeters. So you need an incision of 4 millimeters, which Anil was emphasizing. So all these are points, but I would agree that this is the most reproducible, bisectable technique for the endothelium, reproducible, I'm saying. If you get that 2 little things made in your place, Anil can show how it is made. And I think that is the most reproducible way of bisecting hardest of the nucleuses.
Thank you, sir. Nicely, the differences between the my loop and the snare technique. Yes, Mathur Saab, please go ahead.
Yeah, sorry, I have the OT, so I could not attend all. This is the snare I received, thanks to Dr. Anil Shah, I received 2 days back. Dr. Devashi was telling you snare, can you see?
Yes, yes.
This is the loop. He made this, and he made like this. I received from him 2 days back, thanks to him, because I am doing this a long time. And really, it is very successful, hardest cataract. We are doing it.
Great. Thank you, Mathur Saab. Yes, Dr. Sunil Thangarajan, what about your experience on these hard cataracts? Do you use the snare technique, or you go in for the conventional method?
No, I'm more of the conventional person. I did try tri-sectional person. I'm not too worried about making too small an incision. In fact, I renamed my small incision. I don't call it small incision. I call it SLICS. It's sutureless large incision cataract surgery. And I think that is more apt for this surgery. But I have actually asked Dr. Shah to send me some snares. And I'm going to try these. No harm in trying this. So, but as of now, I'm more of the conventional person. That's right.
Thank you for giving a newer nomenclature. I think many nomenclatures are coming. Thank you for adding one more to the basket. Yes, Dr. Deepak Mishra, we can hear from you, please. What about your experience? How do you manage these hard cataracts?
Sir, I would like to take some tips from the Anil Shah sir. How you manage in the shallow AC using this?
No, snares, when we want to use the snare, there are few criteria that it should not be used in hard, when the AC there is a pressure. when there is a intraocular pressure is high, or when there is a shallow AC, and when you are not able to move nucleus free floating into the anterior chamber, then you try to avoid snare, because free floating nucleus is more safe and shallow AC can be more traumatic. So I avoid using in shallow AC. And when there is no free floating nucleus in the anterior chamber, hypotone is must.
Thank you, sir.
Quick comments from Dr. Ashok Nanda, and then we move on to the Brazil chapter. If anybody wants to ask any question to Dr. Anil Shah. Yes, the Ashok Nanda, sir. You're muted, please. You're muted. Please unmute, sir.
Sorry. I do agree about the use of snare being a very effective way of decreasing the size of the nucleus. My use of snares are only in cases of hard cataracts, because for most of the other cataracts, a 5 millimeter SICS would be fair enough to go for any grade 3 cataracts, and anything above grade 4 are very super hard cataracts and you would like to remove it within 5 millimeters of size, then it is ideal to go for a snare technique. Of course, it is very safe, not very difficult to learn also.
Thank you, sir. Dr. Nito, Dr. Rafael, Dr. Philip, you have any comments to make on this snare technique? How did you find it, the Make in India kind of technique? And if possible, can you emulate in your hands? And is it possible? I just would like to know from the Brazilian end as well.
Well, I tried to use this snare a long time ago, some 10 years ago, and I can't remember where I learned it to fashion the snare, but it was very similar to Dr. Shah. I think someone talked to me, I can't remember, but I used it for a few times and I like it very much. But as I do not did at the time manual cataract surgery too often, I almost always resort to phaco and other techniques that I use when approaching hard cataracts. Recently, I had the opportunity to use the MyLoop device, but I had two sent to me, and both broke after only a few tries. And I think the idea is very good, and I congratulate Dr. Shah for his for devising this device, and I think it's a very useful tool for approaching very hard cataracts. So I would like to have more experience, and after watching some of his videos, not only here, but in our group oculars or surgeries worldwide, I will fashion some for me and try. And so I will try to make some videos and put on my channel.
Thank you, sir. Thank you very much, sir.
So any comments from Dr. Rafael, Philip, or Dr. Noose, Dr. Lincoln, Dr. Wallace? You have any comments? Quickly, we can have it from you.
I have used the MyLoop as well. It's a great technique, but I haven't ever done the snare technique.
I think Anil Shah, sir, you need to send Dr. Rafael your snare. So you can try that, and
you have to teach us how to make it, and we'll definitely do it.
Yes,
I'll definitely send a few snares to you.
Great. Thank you. Yes, Boramani sir, please, your comments, your views. Please.
Yeah, basically there are multiple phaco-fragmentation techniques, but especially in black cataract with a hard leathery cataract, there are leathery fibers adherent to the two segments. So snare, in my opinion, is the only technique. Once it divides the nucleus and the snare comes out, it is 100% division. There are no leathery fibers attached to both the segments. That is the great advantage of snare technique.
Yes, can you come up, please? Till then, we have a question from Dr. Richard. Dr. Richard, are you there?
Better.
Okay, Dr. Richard has asked a question. Can you detail the snare mounting? And he saw an article using the snare with IOL exchange. Is this the same technique? Dr. Shah, sir?
Yes.
This is from our institution, so I would take it up. Actually, it won the grand prize in 2010.
Wonderful.
So it was like you get the optic engaged in the snare. Actually, we put the snare again into a cartridge, into a usual Monarch cartridge, and we cut the side of the cartridge a little bit. So now you can, in the snare, you can engage the optic of the lens, and as you snare the nucleus, you snare the intraocular lens. So it is a way how you can cut and explant a lens through a 3 millimeter incision. So that was a technique from our institution. So yes, I mean, that won the grand prize in 2010, the first grand prize from India in the ASCRS. Yeah.
Great, sir. We are proud of you and your institution. Thank you very much for sharing more details. Is there any other comments which Sahu sir, quickly? You're muted, sir.
Technique, take it forward. It is wonderful technique and one of the weapon in our hand to fight cataract.
Thank you, sir. Manisha, madam, your quick last comments.
Thank you so much, everyone. It's really a lot to learn, and it is really exciting. I did not know this ISMSICS group existed until I became a part of it. I'm really excited because everyone generally, had disloyalty to SICS as time passed, went on to phaco, dropped a few nuclei, got these hard cataracts in which they could not do anything, then, learned SICS all over again. So I think it's a wonderful technique, especially for a developing nation like ours, any kind of lens in any kind of cataract. So thank you so much for including me here. Thank you.
Wonderful. Thank you. Thank you, madam. And Dr. Noos, for your last comments, you want to say something?
Thank you, Geoff. I would like only to congratulate you with everybody, because I'm a little cold, but I would like to thank you the participation of all the Brazilians in this amazing group of very important surgeons in India. I'd like also to thank Neto, who's the one who organized with Kobayashi and Taguchi, the Brazilian sector of the small incision cataract surgery group in Brazil. So thank you so much. It was a nice meeting, and we enjoyed it a lot. Thank you.
Same. We enjoy it, and we want to see that you take it forward.
Thank you. Thank you, sir. Dr. Philip, your last comments, and then we move on to Dr. Saurabh Patwardhan for his last remarks.
Well, I'd just like to thank for this opportunity, and also hope to spread the word on manual advanced incision cataract in Brazil. And it's been an honor to participate and listen to such an awesome lectures today. Thank you.
Dr. Saurabh Dada.
Yeah, thank you so much for this opportunity to present also, and welcome to the group. And I'm sure this technique is going to help all of us to bring great vision to our communities. And I think one more thing, I think Dr. Amolya Sahu sir might be able to add, because as a trainer, I always feel that teaching SICS is a bit difficult as compared to teaching phaco. So I think ISMCS, if I'm not wrong, has worked on simulator and making it available to Indian surgeons for Indian conferences. If you can add few things on that, that will be very useful for us who are training young residents.
Two things we are starting now, global online training program we are starting shortly, and simulator training we are starting another few days time. We have signed up with HMS people, and we are starting mostly in the Pune.
Pune, yeah.
I think signed up.
Okay. Ravindra sir, your last comments, and then we can.
We have a Karnataka chapter where last four weeks, every Thursday at 9 o'clock in the night, we have 1 to 1.5 hours of discussion. We present one surgery and then we discuss on it. I think it's coming up very well. I think that's what is needed. These conferences are of great use, but then presenting one case and all the people commenting on it will go a long way in teaching. That's Saurabh also mentioned that is difficult. On video based, we've been doing it, and people have received it very enthusiastically. And I can share the next link. Every Thursday evening, 9 o'clock, it's there. Everybody can watch it.
Yes.
I think that's one way of learning and sharing.
M6.
Groups, yeah. And
Thank
this
you,
is
sir.
being circulated to all SICS groups, all chapter groups.
Sir, I have
The
attended
Karnataka activity.
It was
Dr.
really good.
Manisha. Yeah.
Karnataka meeting I attended. It was really good. I was the infiltrator, and 9 to 11, it was very nice. I'm getting used to spending my weekends this way now.
Thank you, madam. Goramani sir and Sahu sir, we have a request here. See, many people are asking, like using a small snare technique as well from Dr. Anil Shah, where many beginners also would like to know, like how to use the snare safely without damaging the endothelium and without having the iris in the inside it. So I think we can make a little bit more detailed webinars on this based on the niche topics, having it, because if we try to club everything, then the time becomes too less for one particular topic. So we can have a more detailed discussion on this. Want your views on that, Goramani sir and
Yeah, absolutely. See, this time purposefully, like in US chapter webinar also, all Indian speakers were given only 3 minutes. In 3 minutes, you can just give a glimpse of your technique, just to showcase what Indian surgeons are doing in SICS. But to discuss and detail, you need at least 8-minute presentation and a lot of discussion. So we can again subdivide this into various techniques and go into the details. For example, snare also requires a lot of elaboration. In fact, Dr. Anil Shah conducted wet lab also in the Kolkata CCC on the snare technique, because unless you sit with him, it is very difficult to learn the technique. Isn't it? So every time maybe we'll be elaborating on 1 or 2 techniques for about 2 hours, and on webinar only on 1 or 2 techniques.
I think
that's our motto. Correct.
Yes, now sir.
I think what we are planning after this COVID, me, Goramani, and all this MS Ravindra, Anil Shah, we will visit to different cities and try to train at least a handful of people who can take it forward. Otherwise, it will not exist, So we will distribute areas and start moving and train the next generation. That will be our commitment.
So Shah sir, you have a lot of responsibilities up into your basket. I think we need to have a separate webinar on this, and we'll have a big 1 hour discussion mainly on the snare technique.
Yes, sir, I'll definitely do that.
Now, Srinivas, Ken Shah say a few words as to how did he think of this gadget? It's ready-made, we are all using it, but how did he conceptualize and at that time come out with this concept? If we can say a few words, it will be very...
So I'm practicing in a very small area. It is an Adivasi area, and there are all the patients come with hard cataract. So in 1999 or that time, SICS was just started. Then I came to realize that if I can divide the nucleus intraocularly and remove the small pieces, then it will be better. It will be as good as phaco. So something like tonsil snare or that snare, it came into my mind. But at one time, I realized that if I can make a hole in the needle and then loop it, then the problem would be solved. Because after making the hole in the needle, the snare can be pulled to make it smaller. You can enlarge it, you can make it larger, you can rotate it internally, and you can make it sideways. So all the movements are possible with the snare in the intraocularly, and it is very easy and safe. So after that, I started doing snare technique, and I was not knowing that it is an invention. But when at Nashik conference, it was a small incision cataract surgery. That time, many surgeons were presenting, and then I told chairman that I want to present my technique. And when I presented the technique at Nashik conference in 2000, they were surprised to see the snare. And without knowing anything, they have declared award for me, and that was a great achievement for me in that time. And after that, I have written a book, Small Incision Cataract Surgery, Best Out of Waste. That time, adhesive drape were not available, so I have made a drape with gutka paper, and that is autoclaved, and that you can cover the eye, and then you can keep a towel on that. So there are so many other small inventions. That time I used to make cannulas, I used to make every instrument that is required, even crescent blade and all. That time I used to make, and that is given in the book. And that journey started slowly, and then I continued with the snare only.
Thank you, sir. Thank you for quickly sharing the experience of snare of more than 20 years now.
Yes, sir. More than 20 years.
More than 20 years.
I started.
more than 20 years. You have covered it in 2 minutes. Thank you very much. And we can have a separate webinar on that. And I think here we come to the end of the session. Lastly, last comment from Dr. Mathur sir, our Chief National Coordinator.
Srinivas, I have been talking with Dr. Anil Shah long time for last 1 month almost, when Dr. Sau motivated us to do Snare. And we are now planning to take out the nucleus, not from the bag itself, but from the pupillary area. So he has sent me a lot of snares few days back, and now I am trying. Today I also operated one case from the pupillary plane. I will share the video with all of you, not from the bag, but I moved the nucleus into the pupillary plane, and from there I divided the nucleus into 2 parts. So there are a lot of things we can do that we have talked with Dr. Shah, so that we can make it like Billu, and then we can sell it in a very low cost to our own brotherhood.
Thank you, sir. Thank you very much.
Thanks to Anisha for sharing the Snare with me and with a lot of us.
Thank you very much, sir. Thank you very much.
Thank you, Dr. Mathur sir. Thank you, Dr. Shah. So with this, we come to the end of this, the initial chapter installation launch. And I must say, Dr. Nito and all his team from Brazil, it's a fantastic webinar which has been gone through. So many video bouquets has been presented in just snippets of 2 to 3 minutes, giving us more and more ideas. I think we all learned more and more from this. Thank you for the expert panels, all the suggestions you people have been giving through and guiding us. And on behalf of the national team, I thank all Brazilian ophthalmologists and the doctors, and especially the ISMSICS chapter, the people who have been the main stalwarts like Dr. Nito, Dr. Noos, Dr. Philip, Dr. Rafael, Dr. Richard, and Dr. Wallace. I think hats off to you all. Thank you very much for making this, and we look forward to more and more presentations. We can have an Indo-Brazil meet coming up very soon. We can have it once in a month. And with this, we call it an end. Dr. Nito, yes. Shall we conclude it?
Yes. All the best to the Brazil chapter.
Yes. Closing remarks.
Very much. Thank you.
I'm sorry, my connection is unstable. Well, it's been a wonderful meeting, and I only can thank you. I can't thank you enough for the opportunity to be here and to learn so much from you all. And I thank everyone attending this meeting, and we hopefully we'll meet again soon.
Boa Noite is nothing. For the Indians. Trying to learn more and more Portuguese. So thank you very much. It's good night for Indians, and good afternoon for all our Brazilian counterparts. With this, we come to the end of it. Thank you very much. Thank you, one and all.
Thank you.
Thank you.
Thank you. Bye-bye. Thank you.
Thank you. And all
Thank
the best
you,
to the
everyone.
Brazilian
Thank
chapter.
you. It was nice meeting everyone.
Thank you, sir, everyone. Thank you.
Thank you, sir. Thank you. And I would like to thank Enton